Dr., I think you won the prize for fastest speaker so far. So Dr. Anthony Fung is going to be our next speaker. It's really going to be interesting because we've heard about how to diagnose SCAD from the outside in, and he's going to talk to us about how to diagnose SCAD from sort of the inside out using OCT and IVUS. He's a clinical professor here and is a member of the interventional cardiology group. So.
Thank you. So it's a pleasure for me to be here, and I learned a lot about SCAD and things like that from Jackie. So, we have done some imaging work, and I just want to share with you some of our thoughts on this topic. In the cath lab, we either use OCT or IVUS. They're different. OCT is a little bit smaller, it's light-based, and has better resolution. You can see it clearer. IVUS is also very good, and but the resolution is a little bit less than OCT. Now, in SCAD, as you know, most of the patients present acutely with acute coronary syndrome. Basically, they have a dissection with an acute tear of the vessel layers. So you acutely develop a forced lumen. And when the forced lumen got enough pressure, then it can cause some compression of the true lumen. So this is a cartoon of the an artery. The artery has a lumen, and then it has the wall. The wall has three layers. The innermost layer is the intima, and then you have the media and the adventitia. And typically what happens is that you have a tear, typically in the media, but not always. It could be adventitia, but typically in the media, and you tear the vessel. So now you form a hematoma, and the hematoma externally will then compress the true lumen, so it manifests as a acute coronary syndrome. Now, if you think about that, and if you think about the imaging with a catheter inside the coronary artery, what are you supposed to see? You were supposed to see an intermedial membrane, and this is supposed to be the classic, and this is the hallmark of it. You see intramural hematoma, you see a double lumen, and you see sometimes you see localized fenestration of the two lumens. So just to give you some idea what you're supposed to look at. So this is the OCT, and this is the imaging catheter sitting here. There's a guide wire here, and the guide wire gives you an artifact. So this is not a break, but this is just an artifact from the guide wire. So this catheter actually is sitting in the forced lumen, and this is where the tear happened. And so this forced lumen is now under pressure, is pushing, tearing up the intima, and this is called the intermedial membrane because the media got split right here. And so this is forced lumen full of hematoma, and it's pressing against the true lumen, which is now small. So what is sitting in here is blood, and if it's old enough, then it becomes a hematoma. So this is the classic. Now, in some instances, you actually see a tear like this, and so this is an actual tear. And in our experience, I think you see that in about 30–40% of the cases have a tear. So many of them don't have a tear, or it's just to see the hematoma. This is a paper that was published a few years ago with a different appearance. So you can see this is OCT at the top and IVUS. And you can see that OCT has much sharper images. You can see them very nicely. So in this case, you see a true lumen here, and then the hematoma surrounding it. This one is the hematoma surrounding the whole vessel. This one has a tear, and this one has a clot sitting inside in intraluminal thrombus. And now look at IVUS. It doesn't give you as clear picture because the resolution is not as good. but you see the similar type of thing. But what is nice thing about IVUS, you see a much deeper penetration. So you can see the vessel in relationship to the lumen, and the relationship is better seen. This is similar situation, and you have this hematoma, which is B shape. Sometimes it's this shape. This one, look at the IVUS, it gives you some more detailed examination actually of this, because this is a hematoma, but then there's clot formation now. You can see this layer of clot. And the clot sometimes can be in the lumen. In this particular case, it's more well-formed hematoma, and then the clot is inside the lumen. So I think these imaging things are complementary, give you a bit of different information. This slide basically wants to illustrate to you that when you do an OCT, although we cut it section by section, at different points, in this particular case where this is dissected, the black is the hematoma, and you can see that the hematoma twists and turns and spiral around. In this case, the hematoma is like crescent, and then it's surrounding the whole vessel. In this case, in here, it actually broke open, and you have a tear here, and then it goes back to circumferential. So depending where you scan, and so the intracoronary imaging obviously give you multiple views of the same problem. Intravascular ultrasound, I just want to show you that there are different types. So this one is a standard intravascular ultrasound with 45 megahertz, and you can see that this is a vessel, and then your hematoma would arise here, and you can see, and the picture is quite nice and fine. But there are things that use 20 megahertz. In this case, you can see the vessels are not well seen. You can still make the diagnosis. You see the hematoma eventually appear here, but the quality of the images is way less. This is 20 megahertz. So I just want people to pay attention to this. If you're going to use IVUS, you should use a higher megahertz, and that give you a better resolution, better picture. So intracoronary imaging, you've seen a lot of pretty pictures, but I want to show you one case in which I can actually show this one. But this was done in I think 5-6 years ago, and I must admit that I didn't do this case. But anyway, so somebody else did this case, and they were not suspecting SCAD, or they were not sure it was SCAD. But you can see this is this patient presented with acute coronary syndrome, and you can see that the vessel is not quite normal. And it was decided that they go ahead and do imaging. And so first thing they did was to wire the vessel, and you can immediately see that is a disaster, and the wire has gone into what looks like a false lumen. And the operator was skillful, and he was able to put a second wire back in, and he actually used a microcatheter to do an injection to make sure that he was actually in the proper vessel. But the vessel is now totally dissected, and the patient was having acid elevation, and it was bad, and he did an OCT, and this OCT is very interesting. You can see that there's a membrane, of course, and see this dissection curve up there, and so a spiral dissection of the vessel. And of course, the patient was doing poorly, and so he managed to stent, put a bit long stent here, and now the flow is reestablished. But you can still see there's a lot of dissection distally, and after a total of 3 stents, and everything was restored. So this case I illustrated to you is beautiful pictures. However, there was a lot of price we paid for that one because it ended up with a significant complication. So when people think about SCAD, they're not sure what it is. There are differential diagnoses. It could be atherosclerotic disease, it could be spasm, it could be takotsubo, could be embolism, could be other things. And so is it reasonable to think about doing intracoronary imaging to help you? I think Jackie showed this classification earlier. There are the typical dissected vessel. So those ones are very obvious. You probably don't need to do anything further. But then there are the type 2 and the type 3 SCAD. Maybe those cases, the intracoronary imaging can help you. But how safe is that? There's not a lot of literature on it, but this is one small piece of information that you can have. This was presented at ACC by Jackie on the Vancouver experience. 470 cases of SCAD, and there were 36 of them, or 7.6%, had intracoronary imaging. Most of them are OCT, some of them are IVUS, 1/3 of them are STEMI. Type 1 was in 11%, type 2 in 61%, type 3 28%. And in 2 cases, or 5.6%, they could not successfully complete the intracoronary imaging even when they tried. And there were complications in 3 patients. 3 out of 40 patients had complication. One of it was a guide dissection, which is the one that I showed you. There's another one that was OCT catheter dissection. There was one with transient SC elevation. So all in all, 8.3% of the patients who underwent intracoronary imaging had some kind of complication, which can be very bad. So now we're not used to this kind of complication rate. When we do atherosclerotic disease, when we need to do OCT or IVUS, the complication rate is probably 0.3%. So this is significantly higher. In this series, they saw intramural hematoma 100% of the time, and intimal tear in only 33%. So I want to summarize by saying that it is reasonable to consider intracoronary imaging when a diagnosis is uncertain, and when you really need to know. And this is a very judgment thing, is when you really need to know, perhaps never. Perhaps always. I mean, it is a very judgment thing. And this, I think, is sort of the art of medicine. And it's really hard to give you definitive guidance. There is a risk. And some people would say, you know, it's a small risk. Well, definitely small for the operator, but it's not so small for the patient, right? And so we're talking about an 8% risk, maybe a little bit less, maybe a bit more, but it's in that kind of ballpark. So we have to think a lot about that. Because when you think about it, you know, when you do a PCI, you quote the patient, the risk of significant complication, you're probably talking about 1 or 2%. So, you know, this is not a very small risk. When you use imaging, you must be very careful. OCT has higher resolution, it's probably easier to interpret. It doesn't need as much training. IVUS is a lot more difficult, but IVUS is very good when you have to limit contrast, your ostial location, full distal fold. But there's a new high definition IVUS, which I have no personal experience whatsoever because it's not approved yet in Canada, probably coming in a couple of months. But I know that some of my colleagues in the US have experience with it, and they're very enthusiastic about it, and it seems to be a very good imaging modality for SCAD.